Hi everyone, welcome to this session today, the last of our workshop series for the Virtual Patient Challenge 2020. Today we have the Clinical Skills Mastering Seminar by our very esteemed Professor Chintamani. So not taking much of your time, we apologize for the delay due to some technical difficulties. I'll give it over to Sir. And meanwhile, I'll be sharing a link on the chat box, which will be the pre-event form. So kindly fill it ASAP and feel free to ping me if you have any doubts. Kindly do not uh, populate the group chat. Just send you any doubt that you have regarding anything or the form to me privately, to the host privately. So I think that should be fine. So we'll just begin in a few minutes. Thank you. Hi everyone.
Hello.
Hello, good morning, sir.
Morning, everybody. Yeah, are my slides visible?
Uh, s- Sir, I think ma'am has stopped sharing the slides.
All right, I'll just do that.
Yes, sir. The
Morning,
presentation is
everybody.
visible now.
Am I audible?
Yes, sir. You're audible.
Can you type in the chat box? You're trying to get a good whiteboard for all of you. So that could you type your message if I'm audible? Am I audible? Am I audible?
Yes, sir. You're perfectly audible.
You see my slides? That is what I was trying to know. I've done the sharing. I'll try again.
Yes, so the slides were visible previously, but they're not right now.
Are they
They
visible
were
right now?
not yet, sir.
Can you see the screen now?
Yes, sir. It says you have started screen sharing.
All right. Can you see the screen now? I'm in the iPad screen.
Sir, actually, you're sharing the screen from your laptop, so that's why I think the iPad screen is not visible. We can see
I'll
your
just
laptop
stop.
screen.
I'll stop. That's a good point. How about now? Can you see the iPad screen?
Sir, actually, I would like to request ma'am to check the connection. It's probably the iPad has exited from the Zoom call. I can't find the iPad.
Okay. Probably there's some connection issue. I think it is showing now. Is it sharing?
Not yet, sir.
It's on here. It's showing yes.
Yes. Yes, sir.
I
Now
think
it says it has started screen sharing.
first slide.
So it's yet shows it has started screen sharing. It will probably take a minute.
That could be the reason. I'm trying, maybe today being a holiday of a different kind.
Right, sir.
What I'll do is the iPad business is not working. So I'll share my screen. I think that will be much better. I would have liked
Right,
it
sir.
on iPad.
Right, sir. Sure.
Is the screen visible?
Not yet, sir. It will probably take a minute or so, I guess.
Switch it on. Switch it on. Now, can you see the screen?
Yes, sir. It says that you have started screen sharing.
Are you able to
Yes,
see?
sir. Yes, sir. It's visible perfectly now.
I think for iPad would have really helped because I usually like to use the talk and board kind of teaching where you actually learn more. So, could you check with people whether they're able to hear me properly, or maybe I can use the chat box?
Hi, everyone. Can you please type out if the PPT is visible to you? It's visible to me.
All right. And now the second question, am I visible?
Yes, sir. You're visible.
Okay. So we'll start, I think, with whatever we have. It's more of talking, and I'll be more interested in interactive sessions. You can ask questions and we can proceed. What we are supposed to do today is to generally discuss as to what is the relevance of clinical learning and teaching and what has changed over the years. Because I personally have a very different view on it. There's a very, very important editorial that I published some years ago. Clinical science, are they still relevant? And that itself indicates that there was some doubt in my mind. Now, what I did was, I mean, I could have taken up any number of examination features that you people can see on my YouTube videos, but I picked up ulcer and swelling, which is most relevant to undergraduates, to everybody for that matter. I'm not trying to, I mean, differentiate between under and postgraduates. It doesn't really matter. Wherever you are, you can start from where you are, and this is one correct way of approaching it. Now, when you're approaching an ulcer or a swelling, you obviously will take a history. And that's what I was trying to do on the iPad. It's a shame that iPad didn't work, but I'll try to cover it up in my by speaking about it. Hopefully, it will make sense. So that is about what we are discussing today, and the aim is to know at the end of the day what to do when you're going for the examination or taking in a patient. I'm trying to open up the chat box. Anybody who cannot see me or clearly hear me, it is. I mean, you can just now type because the connection today is unfortunately not good. We've generally been blessed with very good connection all these days, and anyway, doesn't matter. So, how do you approach an ulcer or a swelling is what I'm going to discuss, and then I'll take one more presentation on how should you approach your examination at international level, at national level, when you're going for the assembly, going for Royal College exams, or all these exams that you would be very, very, very keen on going for. Well, the empty slide was essentially for me to write something, so that part is missing. What is an ulcer? When we are talking about any situation in surgery or in medicine or in gynae or in ophthalmology, what do we do first? We talk to the patient, and that's called history taking. When you take history, for convenience, we have divided the history taking into presenting complaints, which is what the patient comes to you with, or the problem that the patient has got. And usually, the patient would have too many problems to handle sometimes. And you may not find it very relevant to put them down into one or two points. But generally, they will have some prominent symptoms, and you put them in a chronology. You want to not only what is history. If I have to describe the history of Indian civilization, I'll go back to the Vedic times and I'll trace it upwards towards the time today. So chronological order is mandatory. Same thing applies to this history. So no rocket science there. And don't get confused when you're taught in third year, do this, don't do that. No. Essentially, history is what the patient tells you. And what are you supposed to do? You're supposed to make it relevant, scientific, and put it in the right perspective. If you do that, it will automatically fall into chronological order. Giving you an example, suppose a patient says, I've had an ulcer in my right foot for the last 3 months, and it has started paining for the last 20 days. And now it has started discharging for the last 7 days. And for the last 3 days, there is itching around it. So I have put it already in a chronological order. But the patient may not remember all the time what started first. So that's what you're supposed to ask. So as a clinician, you will first take down what the patient says, and then you will organize it. That's what the entire history taking is all about. I'll definitely talk to you about 15 common mistakes that examinees make in an examination at international level. That will be at the other end of the talk. But remember, don't cram up these past books or read from books that make you pass your exams, and especially the MCQ books, which have destroyed our learning and they've taken away our minds. I mean, we are not able to think. You're too bright to be wasted. That's why I'm trying to teach you all this. Importantly, try to therefore learn the reason for doing it. So first you know why, and then you should know how, and then you know why, what, and how. How you should do it should be the last thing. Don't start with the how, which is the usual scenario, right? Now, so first thing is presenting complaints. Some books mention them as chief complaints. No big deal. It's the same thing. That's why they call them chief complaints. Not that patient doesn't have other problems, but these are the prominent and the most important problems. Excuse me. Now, if you have understood that part, you will have to elaborate the history. That's why we call it history of present illness. Now, there is a history of everything that you can have in life. About the illness also, there is a history. So you'll start, how do you start history? When everything was well in the world. Then gradually the world started undergoing those changes. Then came humans and they messed up with the world. The animals went into the forest. Humans came into the societies. Societies got further confined to some elites and the poor ones. So, you've built up a story. And that story is history taking. Nothing, no big deal again. Don't blame a patient for not giving you a good history. It's always the person who is taking the history and sharing the history to be blamed. So once you talk about history of present illness, if you want to divide it mathematically, as I teach my students, I'm teaching you all, divide it into positive history and the negative history. Now, in another 3 minutes, your history is all over. Don't worry about it. Note it down somewhere and you'll be all done. Now, what is positive history? Positive history is what patient tells you, right? Patient tells you something like very commonly you're taught in your clinics, unfortunately, sometimes in all clinics. Repeat what the patient says in his language because that is something which is expected by a lot of people. How will the patient know the scientific side of it? So you repeat it and verbatim you should do it. But that's absurd because you cannot have it verbatim. Verbatim would mean what? I give you a classical example, I always give it. That is, the patient says, it's a classical case of dyspepsia, but how the history was delivered by the patient was, I find some gas in my tummy, which gets too big for me in the abdomen. Then it climbs up to the thorax, gets into my neck, and comes out of my right ear. Please put it down in the verbatim English translation. So naturally, that's absurd. What does that mean? This is dyspepsia, belch. So we have words for it, and when we have words for it, we are not bothered. We don't try to, uh, you know, replicate the patient's words. So that's not a correct statement, but you often hear that. The purpose of that statement was that you should not miss out what the patient is saying. You don't necessarily need to use the vocabulary of the patient. That is what is important. Comes the role of, you say a swelling was approximately the size of an apple, then it became the size of a coconut, and then it became the size of a watermelon. Now, you know that apples come in all sizes, so do coconuts and watermelons also. So it is absurd. When you're saying approximately some size, you're saying this big, or that big. You can always say approximately so many centimeters. Because what are you trying to illustrate? History of the patient's illness. And what does that mean? Onset of it, progress of it, and present condition. So to know that, it started off with the cell giving 2 centimeters in diameter, approximately. It became the size of an orange, roughly about 5 centimeters in approximately, and then it became okay. I've been muted. Is my screen visible now?
Yes, sir. You're audible now.
Is the screen visible?
So the screen isn't yet visible, sir. It says your network bandwidth is low.
No, can you see the screen? Yes or no?
No, sir, not yet.
Oh, that's a straight answer. Please give me an indication the screen is visible. I.
Yes, sir.
Now it is visible.
Yes, sir. Now it's visible. It's visible now, sir.
Now I was muted by you, so I'm not able to see. Is the screen visible now?
Yes, sir. The screen is visible now.
I think the others now muted me. Can you hear me?
Yes, sir. Yes, sir. We can hear you. And we can hear the screen as well.
So, okay. Now, so I was trying to talk about the. Please keep indicating in between the problem because it's giving trouble. If I'm not able to know, then I am blinded to. So I want to know whether. Okay, I'll talk to them directly. Can you all indicate if you can hear me and the slides are visible? Please type it in the chat box.
So the next slide isn't visible after you moved on to the next.
Oh, they had to move. No. Is the slide visible? Am I audible? Yes or no? Answer that.
Yes, sir, you're audible, but the slide isn't visible now.
It is not visible.
It shows that you're sharing.
Write in the chat box. I can't hear you well. Connection is not.
Okay. Do indicate in the chat box as speaks or asks.
Is the slide visible now? I can't see this. Hello, the organizer. Am I audible?
Yes, sir, you're audible.
Screen visible.
Yes, sir, the screen is visible.
So that I can start. No, so I'm blinded to it. Each time I get muted at your end, and I have to struggle to find it. So please kindly
Sure, sir, we
indicate so
apologize.
that I know the flow. No, that's okay.
Right, sir. No.
I'm sorry about it. Connection could be a problem. I don't blame you guys, but just keep me informed so that I know
Sure, sir.
where it is. Yes. Uh, so I was about the history part of it.
Right, sir.
Tell them to mute others, please. Thank you. Now, I was talking about the positive history which the patient gives you. And then there is a very important history, which is called the negative history. If I have to mark somebody, I'll mark that person on the negative history because that's a question you are going to ask. Suppose the patient gave you the history which I mentioned, your question will be very direct now. Now, is there any history of losing appetite? Asking directly, didn't mention. Is there any history of any correlation with the meals that you will ask? Is there any history of postprandial uh, relief in the pain, which would indicate duodenal ulcer, or if there is an associated vomiting following pain? Now, these are questions that you will ask, which are not there in the beginning. The patient. That's called a negative history, and it's so important to have the negative history being taken by a presenter or a clinician. That is you. And remember, if I have to judge somebody's clinical based on negative history rather than the positive history, because positive history is what the patient tells you, and negative history is what you find out from the patient, learning of the disease. And then comes the question of other points in the history, past history. Past history you would take, very often you hear people say, there is no past history which is relevant. Makes no sense. You should be very, 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 very deliberately doing something in here. What is that? Patient has an ulcer. Okay, let's stay to the patient that I just mentioned. Ask the history of any surgery in the past, any history of taking any medication in the past. You'll say, I'll call it in the treatment history. The treatment history is also a part of past history, or if it is taken in the past. Otherwise, it's the present history if it is taken in the present. Now, I'm sure I'll get questions at the end, and I'll answer all of them. Please don't worry about it. And I apologize to all of you for whatever you're not able to hear or see. We'll compensate because the connection today is not great, I must confess. Coming to the sorry. Now the negative history would be important, and I've told you why. Past history would be important. I just told you why. But remember, past is connected to present. So suppose somebody had Diabetes, don't call it a past history of diabetes, because once diabetic, always diabetic, which would mean there is a continuous history. So there's nothing like history of diabetes in the past and there's no diabetes now. Once diabetic, always diabetic. Hypertension is not a past history. Once hypertensive, always hypertensive, generally. So don't make them into past history. You can put them as comorbidities or coexisting morbidities. That's what you can do. Then comes the important or relevant family history. What is family history? I've seen it very commonly that you end up saying nothing significant. That is a very poor and a lazy way to take the family history. Family history should be connected to the disease you're talking about. Say breast cancer. Or okay, let's stick to the same case. You may have upper GI symptoms in malignancies, in benign conditions. You can take a family history of, say, any gastric ulcers or cancers in the family which are related directly. If it is a breast cancer, any history of BRCA related cancers, BRCA1, BRCA2 related cancers, you know that they have breast cancer, ovarian cancer, colorectal cancers, pancreatic cancers. So once you mention that, the examiner feels very good about it, because that clearly means you are aware that family history is very important in certain cancers, certain diseases, because certain diseases are indeed hereditary and they have a familial basis. That becomes important. Excuse me. Similarly, we go to the important history pertaining to past I have covered, then to treatment. What treatment did the patient receive in the past? What treatment is the patient getting today? Because suppose you get a pulse rate of a patient at 62, you must take the history where the patient is on beta blockers. So now that history becomes important here. Or if the patient's pulse rate is, patient has got tachycardia, then you must find out if the patient is on some kind of a asthmatic, anti-asthmatic treatment which can produce tachycardia. These drugs can cause tachycardia. So you need to take that, and then also exclude whether the patient doesn't know he's anxious, he doesn't know if he's hyperthyroid. Those features become very, very important, and therefore the history is very, very important. And negative history, positive history, and the uh, and the personal history next would be important. The treatment history I've already told you. The reason why I'm talking all this about is I can go on this, but specifically I'm touching, and then I'll be very happy to take case questions on this. In this workshop, it should be hands-on and you should be able to ask questions at the end. Moving on, personal history. Often you make a mess of that also. Personal history is about four major things. And what are those four major things? It is basically about the kind of person that individual is. That this person type A personality or somebody with some kind of a distinct feature of something. Or patient has got adequate sleep or not, and his appetite, and then you have the addictions and sleep. You take these 4 points. In addition to this, there is no personal history that you are going to waste time on. So divide it into these four parts and take that history specifically, you will be covered. Yes? Somebody interrupted? Okay, so we have to take the personal history in the same manner as I just described to you. I talked to you about family history also, past history also, treatment history, which is relevant. Then I'm coming to some special histories, which I'll talk about at the end. Now, in a lady, it's mandatory, doesn't matter what disease you're dealing with, to take the menstrual history. And when you say menstrual history, it's, the cycle, the duration, the amount, and of course, associated features can be complications associated with it or discomfort associated with it, which may not be a disease, but a physiological discomfort. And finally, the obstetrics history. Now, why is menstrual history important in all disorders? Because there can be disorders like thyrotoxicosis, patient may have polymenorrhea. Hypothyroid patient may have menorrhagia, or you may have, associated dysmenorrhea in certain conditions. I'll not get into the details of each condition. You may have a different kind of presentation in various diseases, so it becomes relevant not only in gynecological scenario but also in routine scenario. Similarly, the obstetrics history, because when you talk about the obstetrics history, it is important to know as to what is the uh, uh, sleep, appetite, somebody has asked, sleep, appetite, addiction, and of course, the individual's personality. So basically, uh, bowel and bladder habits would also come in the personal history. So sleep, appetite, bowel, bladder habits, and any addictions. Now, let's move on. If I am not visible, I've switched on the webcam to stabilize my connection so that you can hear me well and see the slides. I'll get back to you. Don't worry about it. I'll soon be visible. So now you don't see me, then you will see me. Don't worry. Now, coming to the obstetrics history, what is the importance? It's a very, very important history, let me tell you. Certainly in obstetrics and gynecology, I'm not going to dwell into each individual aspect. How many babies were born, whether they were full term or not, how many cesareans were done, whether there was any associated, missed abortions or in general, miscarriages are important history in breast cancer. Say if patient had too many abortions, it is believed that due to unopposed action of estrogen, there can be high risk of breast cancer. And in the personal history, I forgot to mention, especially in ladies, you can take the history of taking oral contraceptive pills, which is not considered greatly relevant today on account of the dose of estrogen come down, but it used to be a very important history for breast cancer and ovarian cancer, and also the hormone replacement therapy, especially in slightly older women, postmenopausal or perimenopausal women. So that is what covers up this part. Coming to obstetrics history, why did I mention that? We know that more pregnancies, full-term pregnancies do provide you protection against some cancers like cancer cervix, but they breast cancer, but they do increase the risk of cancer cervix. So we know that there is a history of risk assessment that you can do based on obstetrics history. So it becomes necessary. Let's move on to some special history that you would take. Suppose the case is GI case. You'll spend more time finding out about whether the patient had the kind of bowel disturbance that you would expect in the lower GI problem, or in the upper GI, would expect patient to have dyspepsia, which we discussed, or pain, which is associated, which got a relationship with the meals, pain that becomes worse on taking meals, which you know that it's associated with gastric cancer, gastric ulcer, or pain that is relieved on taking meals. We normally link it to the duodenal ulcer, then the hurry curry approach, the kind of diet that the patient takes, that has got to do with the duodenal ulcer. So we can always dwell on that particular aspect. Then comes the history of, especially in the lower GI, malignancies, any significant history of weight loss. And I often teach my students a mnemonic for stomach cancer, which is LOADS, LOADS, L for lump, O for obstructive features, especially gastric outlet obstruction. A stands for anemia, asthenia, anorexia. And D for dyspepsia, which especially is of new onset. That is the dyspepsia that happens for the time of 40s, new onset dyspepsia. And S is very important, that is silent. Do you know this would apply directly to same mnemonic for the right-sided colonic malignancies, the cecum and the ascending colon? Same, you can have a lump, large organ. So you can have a silent presentation. It can be a lump, and they tend to have more of the anemia because they have more of cachexia, and they have more of production of tumor necrosis factor because the lumps or the malignancies grow large and there's necrosis in the center, which secretes tumor necrosis factors, TNF, alpha 1, 2, etc., which is what leads to cachexia. And cachectin is one of the tumor necrosis factors. So what does that do? That will cause more cachexia and more weight loss, asthenia as they call it. Anemia because they continue to bleed, and you have melena, which becomes a very important history. These are special histories that you will take in a particular case. Now, can you take a history without knowing about the disease? You can't. And that I'll address in my second presentation, putting the cart before the horse. That is, you people are taught about with this history to be taken in this scenario. It cannot be taught in isolation. You have to understand about the disease. Only then would you be able to understand what history to take, because the eyes cannot see what the mind does not know. And you cannot ask what you don't know. So that is the background of it. That's generally the history. Special histories are only for specific scenarios. Like if you're talking about a Burgess disease case or a limb ischemia case, you take the history of claudication. If there is a patient with mesenteric artery obstruction or blockade or stenosis or narrowing, we take the abdominal claudication. Claudication is a term that has come out of the name of King Claudius from Rome, used to limb. And this is where claudication is classically a pain that appears on the organ getting exercised and it's relieved on organ getting rest. So it is related to the exercise and it is relieved on rest. And that's what makes it a very important history. You know that we are dealing with chronic limb ischemia if the patient has chronic limb ischemia, has claudication. So it will automatically work depending upon a particular condition. So I can't take that all in one go. So let me touch ulcer and swelling, then we'll get back to the history. History part I've covered. If there are any questions, I'll be very happy to take. There's some other histories which I'm sure when you ask me questions, I'll cover. What is an ulcer? Let's get to the brass tacks now. Ulcer is basically a breach in the continuity of epithelium. So it doesn't have to be only in the skin. It can be in the oral cavity, in the rectum, and it can be anywhere. I forgot to mention them. Suppose you're talking about rectal cancer, you'll have history of incomplete evacuation, spurious diarrhea. Would that form a part of bowel habits description in personal history? No. If you have got a patient with colonic malignancy suspected, you would take that history beforehand. You won't wait to take it in the personal history. So please understand, these are adjustable divisions and they're not rigid. This is not an airtight division that I'll talk about bowel and bladder only when I come to personal history. That's not correct. Similarly, bladder habits would be a part of your patient with prostatic hypertrophy or urinary disturbances. You can take the history of burning, urgency, frequency, precipitancy, or all histories related to prostatism. Similarly, when I mentioned about the rectal cancer, the right side cancer, I've already told you the mnemonic. The left side, you can have chronically increasing constipation, worsening constipation, spurious diarrhea. You can have a bleeding, which can be fresh. Right-sided colon, the bleeding is usually the blood is acted upon by bacteria and they have melena rather than fresh blood. Left side, you have fresh bleeding. So that covers up the GIT. Similarly, for breast, you'll have some features. So please try to take it in. This is kind of a template on which you can build a story. It is not the same story each time because every disease has its own story. Every patient has his own story. It will vary. But have an approach that before you take the history, you should read about the disease. So both cart and horse have to go together. It's not that you'll load yourself with information, which is cart, and horse, which is wisdom. You put the horse behind it. Wisdom is basically based on knowledge and understanding. Once you have understood that an ulcer is basically a breach in the continuity of epithelium, don't talk about skin. It's skin, mucous membrane, it can be inside the stomach, it can be anywhere, it can be colorectum, anywhere. The classification of ulcer is based on its etiology. So you can have an ulcer due to trauma, traumatic ulcer, tuberculosis ulcer, tumor, malignant ulcer. So 3 T's. You enjoy that, I know, TTT. So triple T, that is another T. So that will be trauma, tumor, and I forgot the third one because I'm bad at these mnemonics, because that I would rather understand. Tumor, tuberculosis, right? And similarly, you have infections of all kinds, acute and chronic. Then you can have malignancies I've discussed just now. So you can have oral cavity cancers. You can go on the YouTube and watch this video. I have a lot of description of, I would rather want it to be interactive. I'm not going to repeat a lot of things which are there already. So etiology is one division. So you can divide it based on what is the etiology. Duration is another, which I think is more important personally. Why? Because if it is for less than 6 weeks with all treatment, it is taken as an acute ulcer. If it goes beyond 6 weeks, in spite of all treatment, if it doesn't heal, we take it as a chronic non-healing ulcer. So the duration that I'm going to provide to a non-healing ulcer is 6 weeks at least. And then, of course, based on healing. I wish I could use my iPad today. I would have actually taught you on, or you can visit this. This is available on YouTube, where on iPad I've drawn the healing. Remember, when you have to think about an ulcer, imagine a swimming pool without water. I think you can imagine that. And you're walking around it like somebody who would not jump into a swimming pool without water naturally. So you look down and what you see is the floor. What you're walking on is a margin. What is connecting the two is the edge. And what is lying underneath is the base. Confusion? No. So that's also. Now, how do I fill it? I give you the job to fill it with sand. You start pouring sand into it. It's nothing material cells that you're throwing to heal. As sand is into the pool or a ditch, now it will keep getting slopier because it start filling up, and usually as you it keep getting slopier. So the sloping ulcer, the ulcer with sloping edges.
Sir, we can't hear you now. Hi everyone, just a second. Sir is probably reconnecting. Hi everyone, sir is reconnecting. We appreciate your patience. Kindly stay with us. Thanks.
Am I audible? Can you see the screen?
Yes, sir, you're audible and we can see the screen as well.
Thank you so much. I'm sorry about that. Maybe
Sir.
the right? Is it?
Yes, sir. PPT is visible.
So one is based on etiology, which we've just covered, and then is the duration, which I've just covered, and then is the healing, which I've just covered. So if it remains punched out with edges remaining punched out, non-healing. Slopy edges, healing. Now I give you a situation that it heals more than you want it to heal. There's an excessive proliferation inside it. It might actually cause spilling over, which is called a malignancy or ulceroproliferative growth. That is the whole purpose of understanding this concept. So it is a pool. Its ulcer has got edges like this. So as you keep pouring into it, the epithelial cell should keeps on becoming the slopy edges, finally rounds off. But if there's too much on this, the edges, and that would be a malignancy. Now I'll take one by one individually. So you don't have to worry. The etiological classification is essentially traumatic, following trauma, which will be obviously with a history of trauma, but doesn't have to be a major trauma all the time. You may have a very minor trauma, and that can actually cause the ulcer to form. And the second possibility is that the trauma is major, the history is clear, and there's no confusion. That would be major trauma. And the ulcer in both cases can vary in terms of the size, the location, and the underlying damage that it does. Because actually, the whole uh, the whole etiology would be predominantly the etiology of the trauma itself would be the cause of the ulcer. So you would be able to link it to the extent of trauma. Then it can be vascular, and vascular ulcers are very interestingly the common and the ignored ulcers, wherein you find that the ulcer was uh, present at the distal most part, because actually the distal most part is where the blood supply is minimum, and you will be able to label it. And vascular, when I'm saying the word vascular, it doesn't have to be uh, artery only. It can be a venous ulcer also. And the common location of a venous ulcer is, just hold on for a moment. Now, the venous ulcers are classically in the gaiters area. I've shifted a little position to make sure that the connection remains good. And the venous ulcers are usually in the gaiters area, which is in the anterolateral part of the leg. And it actually can produce ulcers in the upper part of the ankle also. But classically, the arterial ulcers are distal and they're as far away as possible. So that's how you identify them. And arterial ulcers would be ones with the floor looking pale. The granulation tissue that you observe is pale, and it is classically associated with also vascular compromise and features of chronic limb ischemia, which partly I've described. In the history, there'll be some features, and there'll be some features in the examination, which you would observe as you go along the story of it. Finally, we may have the arterial venous ulcers presenting in awkward situations, but that's not where you are bothered. I mean, it's not your concern that the position is awkward or you're not able to see it clearly, or you're not able to appreciate clearly. But venous ulcer classically will have all the features of chronic venous insufficiency in the form of the lipodermatosclerosis, or appearance of, or the presence of, uh, the blackening of the skin around, etc., etc. Infective, commonly, as I said, tuberculosis and syphilis. Now, when I'm saying tuberculosis, remember tuberculosis ulcers don't happen in the limbs. They are not common, but they can happen in the neck, along with what is called collar stud abscess, or the scrofula, which is tubercular lymph node that is ulcerated, and you can actually find it. I hope all is visible. Can you all type in the chat box if you can hear me? There's been some internet issue today. Don't worry, we fix it. Can you type in the chat box, all of you, if you can hear me? Hello? Yes, thank you. That's great. So I'm happy. Now, gradually, we'll come to the uh, inflammatory type. Syphilitic ulcers, yes. Not common these days because of the good antibiotic therapy available, because it used to be earlier very common. Now they're not so common because we have a good therapy for syphilis that is available. Importantly, we have any ulcer occurring in the tongue, we need to exclude syphilitic ulcers, because all three stages of syphilis are there in the ulcers that appear on the tongue. You can have condyloma, you can have a primary chancre, you can have a gummatous ulcer. So primary, secondary, and tertiary, all I've covered. So they can be found in the tongue. They usually commonly with a history of high risk behavior. We don't use the term sexual contact or history of contact. That term is old now. If you read it in your books, please don't follow it. It is now all grouped together as history of high risk behavior, which can include IV drug abuse or multiple sexual partners and many things, sharing syringes and all sorts of problems that you're aware of. Inflammatory, of course, is cellulitis. You can have cellulitis leading to an ulceration. You can have diabetes producing a diabetic foot. So that can be metabolic. You can have malnutrition as a cause. Tropical ulcers common, especially with deficiencies, they can happen. Malnutrition with beriberi is known. This can happen in the upper extremities commonly. You can have neoplastic, which is malignant ulcers, or neurogenic, like you have the neuropathies producing ulcers. Even diabetic foot can be neuropathic because of neuropathy, because sensation is lost, so the trauma is not appreciated, and the part is loaded with sugar with less amount of blood supply. And we know that microangiopathy precipitates it, and the rest happens. Bed sores and peripheral neuropathies all can contribute. So this is one way of looking at it. So based on etiology is the classification. Then there is based on duration, there is a classification. Please pay attention. It's a very useful way to understand ulcers. Acute, they move through phases of healing within predicted time, usually 6 weeks, as I mentioned earlier. And they're usually due to some surgical intervention or trauma. Surgery is also a trauma. And chronic are those that fail to heal within 6 months, and there are no signs of healing till 8 weeks. And what are the signs of healing? I've already told you. The sloping edges, good granulation tissue coming in the floor. What is the granulation tissue actually, by the way? Capillaries. When the capillaries start multiplying, they can form a good floor, and they can actually be seen in the floor very nicely. And chronic can have something very important that most people miss out. It's a wound callus. There's a white thickened band around an ulcer. When you find thick band around the ulcer, which is white, it is actually a chronic ulcer, and that is not going to heal. What does it mean? It's called usually a classical feature of a trophic ulcer, which means that's an ulcer that body forgot to heal. How did body forget to heal it? Because it kind of got disconnected, or it was not, it was not directly um, appreciated by the body. What is it that makes the body appreciate any ulcer or an injury? It's pain. So is pain always a bad thing? No, it's the best thing that can happen to you, because pain is what draws attention of the body to the site. And what does pain do? You know that pain traverses along spinothalamic tract right up to thalamus and sends signals to hypothalamus, and then you have cytokines and interleukins all coming down and then stimulating the glycogenolysis, making the polymorphs go towards the side. You send all your armies towards that to make it heal. Suppose there is no pain, it won't happen. So if it doesn't happen, healing won't happen. So if you're asked a very simple question, how do you make this chronic ulcer which has got a wound callus around it heal? Simple. You will just chop off with the blade the 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 callus? So the answer is the knife, the scalpel, which you learned yesterday. Then, of course, there are nutritional ulcers which are related to lack of rest to the part, comorbidities like diabetes, patient on chemotherapy, immunosuppressants, and also steroids, or patient on following radiation, etc. And usually, sometimes the cause is management. You are the cause because you don't let it heal. You don't do adequate debridement, or you don't do dry. This is called debrima in Latin, and debrima means to unleash, which means what? You chop off till it bleeds. So till you get a healthy tissue, you keep chopping it off. That's called debridement. And if you've not done it adequately, you've not dressed it well, you're not taken care of the infection, and if you're not controlled the diabetes, then we are responsible for it rather than the other factors. There's a Wagner's classification, which a lot of people follow. You don't need to worry too much about it, but it's good to know if you are, I mean, it's not a must know, but it's good to know. Grade 0, pre or post ulcerative site. Grade 1 is a superficial ulcer. Grade 2 is penetration into a tendon or a joint capsule. Grade 3 is involvement of deeper tissues. Grade 4 is a localized gangrene, and 5 is it's involving the foot. So mainly for the foot that it was. Parts of the ulcer I've already covered, so I won't waste time. Margins are a junction between ulcer and the normal epithelium, which is what I showed you, I told you, or taught you with the swimming pool example. The floor is what is visible, and base is what is palpated. So base is not seen. So never do that mistake, because you can't see Mother Earth that's lying underneath. So it is palpation. So if the base is tender, indurated, you suspect it to be inflammatory. But if it is indurated and it is going beyond the boundaries of the ulcer, you suspect that it's a malignancy, because that is here the induration is due to infiltration, and induration in the other one, that is inflammatory ulcer, is due to fibrosis. So that's how you differentiate the two. Now, how do you approach it? Take a good clinical history and do a good physical examination. So how would you take a history unless you know the background to how to take a history? I've given you so many causes, so those need to be talked. But if you talk to a patient with a simple trauma, all that history, it may look very boorish to the patient. He may not respond to you, and he may take you for a naive person, and he may not entertain you as he would entertain a senior person. And sometimes you people have a fuss about it that no, they answer all questions that the boss is asking, but when we are asking, they don't respond. The reason is they can judge quickly. Anybody can judge quickly whether you know your stuff or not. So don't approach a patient with limited information. That is going to be dangerous. And don't go there with a lot of information also, because you will just throw it on the patient, and patient is going to get confused about it. Physical examination is therefore an important part of it too. Now I'm quickly going through the history. In an ulcer, what do you do? Onset, whether it was spontaneous, traumatic, secondary over a swelling, was it a change? It was ulceration of a ulcerating tubercular lymph nodes, or over a previous scar. If there's an ulcer over a previous scar, you know what it's called. What is that called? Marjolin's ulcer. And that can become malignant, and that can be squamous cell carcinoma. Duration is important. I've told you why now. Progression is important. I've told you why now. Associated symptoms, pain. Painless ulcers are usually seen in syphilis, neurogenic, diabetic, malignant, and painful. Ulcers are usually arterial, inflammatory, and infective. Easy to remember. The discharge, then the nature of the discharge is important, which can be coming out of the wound. Usually a foul smelling, bad discharge, which is purulent, you suspect it to be an ulcer that is badly infected, and there's a deep-seated infection. So color of it is important. Anaerobic color is very special. How does it smell? Well, it smells like itself. So one cannot tell you. It doesn't smell well. It doesn't smell good. And you have bleeding, which is usually a feature. Why does a malignant ulcer bleed? Am I audible? Please mute yourself. Thank you, Aditi and others. Great. Now I'm getting distracted otherwise. The You have associated symptoms. Pain I've covered. Then discharge I've covered. If it is serious, bloody or pus. Bleeding in malignancy, why does it happen? Remember, you always hear this story. The ulcer bleeds on touch, does not bleed on touch, etc., etc., etc. And some people do a very big mistake by calling what they see red in a malignant ulcer as granulation. That's not right. It's not granulation tissue. Granulation is a healing tissue. Now, malignancy does not produce a healing ulcer. It is a neoangiogenesis, and these capillaries are very fragile. They are not developed properly. In malignancy, very immature cells, similarly immature capillaries, they start proliferating. So when you touch them, they bleed. They can't take care of themselves. They can't contract and stop bleeding. So therefore, malignant ulcers bleed on touch. You'll also take a history of constitutional symptoms like tuberculosis. Any attacks of syncope, history of trauma or burns, naturally, you know why. This will give you a history. Syncope will go towards ischemic history. There can be embolic phenomenon in the form of blackening, blackouts, syncope, or the ulcers developing in the terminal parts. Personal history, you will take personal history of chronic smoking. Smokers have poor healing. Why? They have elastin deficiency. They don't produce a good quality collagen. And what does that mean? They have a type 3 collagen. We want which one? Type 1. So they won't heal well. Smokers don't heal well. There's nothing good that happens to smokers. So if anybody smokes, please let him know that this is a story of fire at one end and fool at the other. Now, hypertension and diabetes, they can contribute. So you know the background. That history is important. And we have taken the history of all consumption. We also please mute yourself, everyone. If I'm not audible, the organizer can point out. Others, please don't. Now, treatment history, whether the patient underwent some surgery or there's some resection done which led to this. There's been a slight delay, so maybe we'll finish it another 15 minutes later. But I'm teaching you something very important, which will be important for you in the exam and in general. Physical examination, whenever you're doing, we have done the history and you heard it properly. Now, how do you proceed in any examination? Remember, I divide examination into three parts. If you remember this, you'll be always happy. Examine the patient, then the region or the extremity in this case, and then the wound. Don't start with the wound, which is a common mistake. So I say examine the patient as a whole, not the hole in the patient. Because what you do is you just examine the ulcer and you don't examine the patient as a whole so that you'll have mistakes. And then you miss out a very basic thing in examination. If there's anything paired in the body, examine the normal side first so that you can compare it. Okay, so examine the patient, which means general examination from head to toe, where you take various features into consideration. I'll consider that. Then the region, and there's nothing like a local examination. You find that written in your books, it's not correct. Local examination is very local. It's the wound that you examine, but you examine an extremity. Suppose there's an ulcer on the right foot, you'll say, I'll examine the right lower limb. Or if there's a lesion in the breast, don't say local examination, you say examination of the breast. If there's a lesion in the head and neck, don't say examine the ulcer, examine the head and neck. That's what I want to emphasize. So examine the patient as a whole and not just the hole in the patient. Important to remember. General examination, what do you want to see? Pertaining to an ulcer, and I'll extrapolate it at any point for you to understand what you do in general situation. General examination is gait. Always watch them walk. Patient with varicose ulcers can have a chronic venous insufficiency and they can walk on their toes because they develop equinus deformity. And equinus deformity develops due to fibrosis and contraction of the fascia. Assess for nutrition. Often you're in medicine or even in gynae, you say patient is moderately built and moderately nourished, which is not correct. And what do? You will describe it by dividing it into three very major issues: carbohydrates, proteins, fats, and micro and macronutrients. It's very easy to do and always have an objective clinical assessment. I'm not talking about biochemistry. I'm talking about not biochemical examination clinically. For carbohydrates or calories, we look for BMI, which is body mass index, 17.5 or maybe 18 to 24 roughly is normal. And 30 and above is malnutrition, 17 and below is malnutrition. Now, morbid obesity is about that is also malnutrition, mind you. So, BMI can tell you straight away. You may weight by height in meters square. Proteins, look for mid-arm circumference, and don't say roughly patient looks pooped out, cheeks are sunken. That's a stupid way to describe it. Be objective, be straight, and firm on it. Mid-arm circumference, pedal edema, anemia. Look for that for proteins. For fat, triceps fold thickness, and you can do it with a vernier caliper. This is what you should carry in your kit all the time. And then micro and other macronutrients. Ask the patient to stick out the tongue. And if it's a bald tongue, what we call as geographic tongue, the vitamin B12 deficiency can be appreciated. Most of the follicles have disappeared, so it becomes bald. If there is koilonychia, you know that it's iron deficiency, basically iron carrying deficiency is what you're able to see. Then you have the BTOT spots in pediatric age group for vitamin A deficiency. So that's it. You just would do in 10 minutes, 5 minutes every minute. Then you can say, patient's got moderate nourishment. Don't contradict yourself by saying patient is moderately built and nourished. Pallor is positive, because that's a contradictory statement. Pallor is anemia, which is a objective sign of malnutrition. Hydration status could be checked as the tongue was sticking out. You could look at the bald tongue and also the dry tongue. But sometimes tongue is dry in mouth breathers and you can confuse yourself. Now, places where you can test for it and you're asked in the exam. Look, especially where you can have this no subcutaneous fat, which is the common site. In adults, you usually do it on the temple here or the forehead. You pinch the skin for about 20 seconds and leave it. In 20 seconds, it should go back. So that's turgor of the skin which you look for. In elderly patient, again, it can give you a false negative report, false positive report. And in babies, you look at the abdominal skin. So this is how you look for hydration. Otherwise, the tongue is a good enough measure. Vitals, compare them in all the four limbs, especially in an ulcer. This is pertaining to an ulcer. I'm just trying to extrapolate, so don't get confused. You don't need to examine pulse in all limbs in all the cases. It's a good practice, although. But in a vascular disease case and an ulcer which is non-healing, it's necessary. Because in coarctation of aorta, you can have, the difference in the pulse above and in the upper limb and the lower limb. Even blood pressure can be different in the upper limb and the lower limb. That's why they insist, especially in the vascular disease case, you should take pulse and blood pressure in all the four limbs. And look for pallor, icterus, clubbing, and don't please remember that pickle nonsense. I've seen it being spoken by people. These mnemonics are useless. The pickle is negative, pickle is positive. That's ridiculous. And don't say no lymphadenopathy, because that would be a wrong answer. The answer is no generalized lymphadenopathy. And generalized lymphadenopathy is when two or more than two non-contiguous lymph node regions are enlarged. Now that is called generalized lymphadenopathy. And use that term. Don't go by size alone. If the lymph nodes are palpable in more than two non-contiguous regions, then clearly you're dealing with generalized lymphadenopathy. Cyanosis, icterus, cyanosis is not something, you'll not get a cyanosed patient in your exam, but you can see central and peripheral cyanosis. Peripheral is due to various other factors, central is due to cardiac causes, you know that. And you can have a false positive, negative in a patient who's got a hemoglobin which is very low, because you need some hemoglobin to weak. I'm back with you. I'll start quickly sharing the screen so that I don't waste any time and I'll get on with it. I'm just about to finish. Organizer, is the screen visible once again?
Yes, sir.
Yes,
The
sir.
screen is visible.
Thank you. And so we've done this assessment, and then we must not say no lymphadenopathy, because you can't examine every part of the body for lymphadenopathy. So don't say that. So term is generalized lymphadenopathy. Pedal edema. Usually you look for pedal edema. Where do you look for it? You look for it at some bony prominence, and especially pedal means lower part, foot. So look at the medial malleolus, and I also advise that you do it on the shin, which is the bare area of the tibia. Press it for 20 seconds, and because you can create a dent anywhere by applying pressure, you should allow it to fill up. If it doesn't fill up in those many seconds, then possibly you're dealing with a pitting pedal edema, and a non-pitting is usually suggestive of lymphedema, etc. But pitting is usually classical for fluid. It can happen in anemia, in hypoproteinemia. It can happen in cardiac disorders. We know that, and so the terms are very specific. You don't look for icterus in the conjunctiva. Often I hear this mistake.
Surveillance malaria is under regular surveillance under IDST. What is IDST?
Now, the icterus is seen in the sclera, not in the bulbar conjunctiva. Now, and then you're down to limbs. I'm back to ulcer, but I was just trying to give you an example of all the other ways to look at it. So don't just start with head to toe examination. So I would, if I was to examine, I'll mention first in what position I examined the patient, and that I had taken an informed consent, and that I had examined in the presence of a lady, if it's a lady, or otherwise a gentleman, or a chaperone, which is male. Examine both limbs, normal side first always. Don't just examine the whole, as I said. Don't go for the ulcer. Always say, I've examined the limb. Suppose this is the right lower limb. You just examine the right lower limb, but examine the normal side first. Anything paired in the body, whether it's breasts, eyes, limbs, examine the normal side first. In some parts, normal side can guide you towards abnormality, because especially in breast, we observe that some women have different texture of the breast. So you may take it for a lump, which it may not be, just nodular breast. Attitude of the limb, what position the patient is keeping it in. Berger's disease, they normally hold it up and they hold on to the limb because they want to improve the blood supply. And sometimes they'll keep it hanging down for the blood supply to improve. In venous causes, they usually keep it elevated, which relieves the edema and the pain. Any visible deformity in the form of, any old fracture that is malunited, etc. Apparent lengthening or shortening becomes important, which can be a part of fractures or injury to the hip. And apparent wasting of muscles, which is a sign of chronic limb ischemia or disuse atrophy. Don't always take it as chronic limb ischemia. It can also be disuse atrophy. And then you have, the appearance of the skin. If it is a shiny skin with loss of hair and the wasting of muscle, with the desquamation or multiple areas where there is no top layer, you can suspect it to be chronic limb ischemia. If the local temperature is reduced, so you have the painful, pulseless, pale, and actually paralyzed part. So you look at it that way. Look for any discoloration, which I mentioned. If there is a discoloration in the gaiters area, that is, you have a suspicion. Gaiters area is the area which is just about around ankle and above, where the gaiter used to be worn by riders, and also the soldiers wear it when they're walking in the trenches or in the forest to protect themselves from snake bite. This is the most common site because the pressure in the vein is maximum here, and venous hypertension is what leads to seepage of blood outside the veins to cause collection, and then it breaks into hemosiderin and other products, and that causes blackening, and later on that may ulcerate and produce a venous ulcer. And look for features of chronic limb ischemia, as I've just mentioned. So important. Then you examine the ulcer. You can see this ulcer here. This is just an example. And now when I'm looking at it, I'm using the cursor to show. You can see that attitude is the patient is holding on to limb, but he's holding and he's letting it hang down. You'll find beautiful description of ulcers in my YouTube video. Please do watch it. I'm describing it here. You can see don't start jumping to dry gangrene here. It is there, but don't jump to it. So I'll start by describing the attitude of the limb, then the visible skin changes. You can see the desquamation here, and then there is a visible ulcer and loss of tissue. And you can see it's full of pus. You can see the tendons and the bone. The ulcer has margins which are regular. And can you see the wound callus here? This is the wound callus. My cursor is going on the wound callus. That's showing that it's not a healing. It's a non-healing ulcer. And this is all dead. So there is there are all the features of chronic limb ischemia in the form of a shiny skin, loss of hair. You can see that. I've not shown you the normal side, which you should ask for. I'll show you soon. And also take a history whether the patient underwent some kind of a debridement, because that can be a false sense of healing or non-healing ulcer, because you can see some granulation here, but this is not truly a healing ulcer. That's a line of demarcation. A line of demarcation, or LOD, is similar to LOC. That is, there's a lot of activity here. Pathologically, you'll see lots of polymorphs, macrophages fighting here the bacterial infection and invasion. And this is a hyperesthetic area, like any LOC which is hyperactive, hypersensitive, this is the hypersensitive area. And that's how you differentiate a line of demarcation from the affected part and the normal part. And importantly, you can see that the plantar surface, you can see the arch is flattened, the arch is lost. Patient is probably walking on the heel. Now it is the correct way to do it. See the normal side and you see the abnormal side. You can see that it is looking like a normal limb, no ischemic features, but this has ischemic features, all the features that I described to you. Shiny skin, some blackening, line of demarcation, dry gangrene, which is a feature of chronic limb ischemia. You're often asked the question, why does dry gangrene happen in chronic limb ischemia? It is because, remember, veins don't have their own contraction. So they rely on artery for pushing the blood. And for this reason, nature has kept them in one sheath. When the artery contracts, the veins are pushed, the blood is pushed in the veins. So usually the venous return is based on the negative pressure in the thorax, then positive pressure in the abdomen pushing to the heart, then negative in the abdomen and coming from the lower limbs, and calves serving as the peripheral hearts. We call them calves because they're always jumping around, and they're also called as the peripheral hearts because they push it. There's a pump in the foot also which pushes the arches as you walk. They pump the blood up to the calves which push it up to the abdomen, and then it goes to the right heart. We know that. So when that doesn't happen, there is venous congestion. So if there is a sudden blockade of arterial supply, the vein also gets blocked. There's a pooling of blood distally, and therefore you get what is called a wet gangrene. If the artery is gradually blocking while the venous return is persistently happening, the part will dry up, and that will produce a chronic limb ischemia. That's the reason that you get a dry gangrene in chronic limb ischemia and you get a wet gangrene in acute limb ischemia, because acute is sudden blockade of both, which leads to pooling of blood distally, which gets secondarily, of course, infected, which is also a feature. Now you see another case, which is classically a venous ulcer. This is the gaiters area. You can see the blackening here, and you can see the ulcers happening due to the skin getting eroded, and you can see the varicose veins clearly, right? So that's how it develops in the gaiters area. This is the area where it can develop. You can see a malignant ulcer. I'm showing you all the examples now. The malignancy has eaten through the skin, and you can see the platysma here. This is platysma, all pulled up. It's fixed. It's a big metastatic node. Can you observe something more here? Look at the nose. This is a saddle nose, or also the nose with leprosy. You get it in lepers. So she has an old history of past history of leprosy. So one has to distinguish leprous, lepromatous ulcers also. But this is the classical malignant infiltration of the skin. Now, patient has been walking on this ulcer, and you get what? The blackish discoloration, the ulcer here, and you have to exclude. Some places you can see this is classically a blackish discoloration, but you must exclude a squamous cell carcinoma because the areas where the edges are everted, and you can see that it's a non-healing ulcer. There is nothing like a granulation tissue inside. Classical margins which are beaded. Can you see that? Beaded margins. They are like silver pearls. The answer is straightforward. The location. You join a line between the angle of the nose, or the nose here, and the ear lobule. Above that, basal cell carcinomas are common. The classical rodent ulcer. You can see the margin is irregular and it is indurated with beaded appearance. That is classical. You know that basal cell carcinoma is locally infiltrative. It doesn't produce lymph node metastasis because it destroys the lymphatics when it is actually burrowing deeper. It's called a rodent ulcer for the same reason. Commonly seen in sun-exposed parts, seen in individuals that are fair-skinned and are exposed to sun. Therefore, very common in the high altitude. This patient is a Highlander from the Uttarakhand. So when farming, they get exposed to ultraviolet rays. Common in Australia and places where you get it. Now, another ulcer which is seen in an exposed area, but this is not a basal cell carcinoma because you can compare the two. I'll just show you. Look at the margins here. They are beaded silvery pearls, right? Here, everted edges. But can you see something very, very interesting here? One side is healing, the other side is advancing. This is everted edges. It is called a field fire lesion. What is that? If you put a field on fire, at one end it keeps getting extinguished while the fire keeps going in one direction. Typical of a squamous cell carcinoma. It may be healing on this end, but it is advancing at this end. Field fire lesion. No guesses here. It is straightforward. You can see that it's got a classical everted edges, a mess here in the scalp. It's a squamous cell carcinoma. And can you see that it is bleeding on touch? Just the dressing has been removed. Why is it bleeding on touch? I just taught you, because there is a huge amount of neoangiogenesis. These capillaries are too fragile to be able to withstand any trauma. Now, this is a classical lower neck ulcer. It's a case of mine with, actually, you'll be surprised, which is very rare. Only 84 cases reported, 4 are reported by us. Primary squamous cell carcinoma of the thyroid gland, almost never seen. Even we took it for squamous cell carcinoma involving the skin. Can you see that? But it was it was coming from thyroid, which is very rare, very few cases reported. Now, that's a classical malignant ulcer of the head and neck. I moved on to other areas now, and you can see what? You can see a daylight through it. You've thrown the torch and you can see the light right across. So it started inside the oral cavity, typical feature in a pan chewing person or a tobacco chewer. Because of nicotine in the tobacco, nicotine is acted upon by the bacteria and becomes nitrosamine. Nitrosamines are precancer, or they carcinogens, and they require a contact time. And the contact time being available, because they keep it as Kenny, that's the area where they keep the Kenny. That's the area where they keep the Kenny. And the bacteria are needed because their oral hygiene is poor. You can see the teeth are stained with tobacco, and you can see that mouth opening is inadequate. This is trismus. And you have trismus is painful restriction of mouth opening. It's not just restriction. And you can see the everted edges classically. But can you see that it's eaten through the entire buccal mucosa, muscle and skin? And that's a fungation of a squamous cell carcinoma. You'll be surprised, this is a tubercular lesion. It's a lymph node in the axilla, which is ulcerated, and it has produced a collar stud abscess. What is a collar stud abscess? Collar stud abscess is classically, if you follow my cursor, there's a lymph node which is tubercular. I think I'll show it here. A lymph node which is tubercular. It is lying deep to the deep fascia. When it gets suppurated, it comes out of the deep fascia and comes to lie under the skin or superficial fascia and becomes a collar stud. Typical collar stud, which if you have seen it in a collar, which has got a deep base and a slightly superficial part. And when you open it up, you end up just draining the superficial part while the disease is deeper. Also called as scrofula, which was common in, it's also called king's evil. When tuberculosis became rampant in England in 30s and 40s, and it was a recession time, people were too poor to withstand the treatment. And there was no treatment available at that time. So they will all walk up to the king, who will hold a coat, and he'll touch everyone and give him a guinea. And that was supposed to heal them. The guinea was given to make them nutritionally get better. And it's called the king's evil. So that is what is the story. Now, no guesses here again. You must have seen this question in the WhatsApp group of undergraduate students that I put. This is a phylloids tumor involving the breast, which is fungated into an ulcer, which is going to bleed. This is not going to be treated by any dressings. This will need surgery. You cannot handle it individually. And you know that edges are not involved in, skin is not involved in phylloids. But a classical, again, a squamous cell carcinoma, you can see on the lateral edge of the tongue. You can see the edges are everted. Floor is covered with slough and dead tissue. And if you feel, I can actually put a cursor here. That's the indurated part. So the induration extends beyond the lesion in case of a malignant ulcer, while it stays within the boundary of the lesion in case of any inflammatory lesion. There can be so many examples. And again, and you can see that this is on the heel, and the patient has scar here. You can see the scar here. I think you can see it very clearly. This is a scar, and on that the ulcer is developed, classical Marjolins ulcer, which is changing into squamous cell carcinoma. Now, some benign ulcers can also confuse you. You can see that this is a patient with a sudden, I mean, it's a spontaneous fungation which happened due to strangulated hernia not getting treated. And that's the testis, mind you. Patient got treated, we did the needful, and then there's an ulcer remaining here. Can you see this ulcer is healed now? And we can just put a skin graft. Skin is the best dressing. Whenever you can put skin, it'll actually make the ulcer heal very well. And that is what it's a benign ulcer. You can see the edges are not everted, and you can see the floor has got good healthy granulation tissue. So I am not going to get into further details. Examine an ulcer, inspection, site size, number, shape. Easy. Margins regular or irregular. You can take a snapshot of this. Edge sloping, undermined, punched out, raised, beaded or reverted. I've shown you all. Floor with granulation tissue or with slough. Discharge. If it is serous, it's not too bad an ulcer. Bloody, suspected to be either an artery that is bleeding or it is a malignant ulcer, which is we've got a fragile capillaries. Purulent, there is infection. Greenish, which infection is greenish? Yes, Pseudomonas. And look for the surrounding area for any edema or discoloration. Palpate for base. Induration, is it extending beyond the ulcer? Is it tender? Then that means inflammatory. Look for the local regional temperature and mobility of the base. Examine the limb for neurovascular system. It is very, very important. Most people miss it out. Higher functions in limb, I'm talking about neurological examination now. Sensory system, don't mention I could touch and find out. Go by dermatomes. And the dermatomes in the lower limb and upper limb, you should memorize them. You sit on, that S3. And you start put your hands in the pocket. That is L2, 3, 4. L4, 5 around the knee. 5 is down to the sole and you walk on S1. Then the medial side is S2 and you sit on S3. Look for motor examination in the form of power, tone, movements at the joint. Very important. Look for reflexes, superficial and deep. The deep reflexes in the lower limb are knee jerk, ankle jerk. Superficial are usually cremastic reflex and plantar reflex. And examine all the distal pulsations for rate, rhythm, volume, character, and vessel wall. Vessel wall, because very often the cause can also be atherosclerosis, where the vessel wall is palpable. And under normal circumstances, the vessel wall is not palpable. Character, the rate, rhythm, character. I won't get into the depth of it because that will take a lot of time. I can cover that. And then must examine for the regional lymph nodes, for their number, their consistency, whether they're mobile or fixed or they're tender or not. If they're fixed, suspicious of malignancy. If they're hard, suspicious of malignancy. If they're multiple, suspicious of malignancy. If they're tender, likely to be inflammatory. Mandatory examination in upper limbs. Please remember this. In upper limbs, always examine the supraclavicular fossa because the cause could be there or the result could be there. Now, what do you mean by cause or result? The result could be in the form of, sometimes you have a lymph node there. You have a lymph node in the inguinal region. Always examine, in the case of lower limbs, examine the abdomen. The pathology could be in the abdomen, like a lump pressing on the veins, producing varicose veins, or there's a tumor there, or there is a lesion in the right iliac fossa which is pressing on the veins, or there is an abdominal aortic aneurysm which can have features. Examine for these areas mandatorily. That will help. Now, when you're managing these cases, well, always manage the patient, then the limb and the ulcer. And with that, I'll conclude it. What I would do I've skipped a few of the presentational slides to make sure that you get time to ask me questions rather than me telling you all the theoretical aspect of it. Now, what I would request the organizers is to respond to my question now. Were they all able to hear throughout? And you can type in the chat box all the delegates. Please, can you just write in the chat box? Everything could hear it? Everybody could hear it? Great. Now, please write your questions in the chat box and I'll take them one by one. If there are any questions, please, I'll be happy to take them. Any questions?
So we have a few questions in the chat box. Should I
Okay.
read them for you?
No, I'll open it. Don't
All
worry.
right.
Thank you. All I wanted to know, I'm sorry, there were goof ups, but were the slides visible? I've got another presentation, but I won't do it now because you've already taken a lot of time. I would rather take questions because that's much better and more useful. Well, that's the chat box. I opened it, and it is Sarah Joseph. Yes, yes. Why are arches lost in ischemia case? That is from A. I don't know who is this A, but the answer is arches are lost not only in ischemia case, they're mostly lost in the venous cases. Why? Because in varicose ulcers, there's a chronic venous insufficiency which leads to the contraction, like from chronic lipodermal sclerosis will lead to contraction and pulling of the tendo-Achilles, and that leads to equinus deformity. And equinus deformity, can you put me in the spotlight? That will help. Now, that would make it equinus. When they walk on the toes, the arches are lost. That's one. The other reason why arches are lost is they can be the cause of the problem. That is, they may not be the result of the problem. And how are the arches lost? If there is a chronic disease, like say you have atherosclerosis or you have Burgess disease, it is common to find that there is ischemia involving the foot and the distal part. Then, as a part of an inflammatory reaction, there could be edema and that can fill up these arches. Uh, that was asked by another. Why venous ulcers mostly occur in gaiter area? Why not in other parts of the leg? I think I answered that, Alish Mehta. One is the venous hypertension. You must understand the cause for venous ulcers. The venous ulcers happen because there is a pooling of blood due to gravity and venous hypertension in the lower part. And Gators area is in the lower part of the leg. There's one perforator which can also fail there. The reasons are many. Where there is basically, if you can understand, is venous hypertension, which leads to collection of blood. Like if you have a multi-storied building, if the seepage happens from the pipe, it's the ground floor people who suffer the most. Reason is the seepage occurs where the pressure is maximum. The same thing happens in the veins. So the seepage happens through the veins and it collects in the subcutaneous tissue, which then gets converted into hemosiderin, which blackens it and also causes tissue hypoxia, which leads to ulceration. And there's no fat there, Gators area has very limited fat. Karishma Shaikh, generalized lymphadenopathy once again. Okay. Remember, generalized, there are commonly the mistakes that people make is, they just describe no lymphadenopathy, which is the wrong way to write it. The answer is that you should say no generalized lymphadenopathy, which basically means generalized lymphadenopathy would mean involvement of two non-contiguous regions of lymph node involved, not two regional lymph nodes, two cervical lymph nodes. It will be cervicals, then axillary, then inguinal. So involvement of two or more than two non-contiguous lymph node regions is called generalized lymphadenopathy. Next, can you repeat how to assess fat in journal examination? This is Butwick Deshpande. Butwick, I'm answering that. Remember to look for the triceps fold thickness. Very often the mistake is somebody would end up saying, all right, the patient has cheeks which are sunken. He doesn't look too good. He looks wasted. He looks hypocritic. He looks with sunken eyes. He's lost the temporal fat. It's all ridiculous. Some people look that way. And I've also heard terms like scaphoid abdomen. There's no scaphoid abdomen in the world, which is boat shaped. But nobody will have a scaphoid abdomen unless he's thoroughly malnourished, or it could be a model maybe who's also the same as malnourished. So if you're nourished adequately, you can at best say it's not distended. So don't use the term what we call a scaphoid abdomen. So how do you look for fat? Triceps fold thickness, measure it, and don't describe it as sunken cheeks, etc. I hope that answers it. Ulcer site in beriberi can be multiple. It can be in the tongue also. Triceps fold, somebody has answered already. Well, smart guys. Parth. Sir, is there any ulcer which is below the line joining the angle of nose and ear lobule, like the one you explained above the line? Okay. Well, I like people who are fussy, so I'll answer that in the way you will understand. It's actually the line changes now quickly. See, from the angle of the mouth to the ear lobule, draw a line. Above that is a common site for basal cell carcinoma. But is that the only place you get it? The answer is no. If you're interested, you can read my own publication on basal cell carcinoma. In fact, there's a book I've written on malignant ulcers of the skin, where I've described that they can happen anywhere. In the foot also I've described basal cell carcinoma, but they commonly where the ultraviolet exposure is there. So where will you get ultraviolet exposure? Usually this part. This used to be covered areas, but you can get it below this. Otherwise, below this you can get malignancy like squamous cell carcinoma. I showed you one case. You can get tubercular ulcers. You can get the other types. Then is and everybody who's asked a question, when the question is answered, please type in the chat box that you heard it and you're satisfied. Uh, Question by Dr. Bushra. Sir, should skin tethering be mentioned when platysma is involved? Is it a sign of infiltration always? It is a sign of infiltration. That's a good question, Bushra. But remember, always is always wrong in surgery, and never is never right. The same applies to life. In life, always is always wrong. Never is never right. Everything changes. But when platysma is infiltrated, it's a feature that skin is just about waiting to get infiltrated. And you call it, there are various signs here. You turn the head to one side and you'll see that there's a pulling of this, stretching of the platysma on that side. That is, some people call it platysmal sign, but I am not insisting on it. In that picture, you saw that platysma was infiltrated. It's a feature of involvement of, because platysma is what supplies the neck. It is the bread and butter for neck. Why? Platysma is called the fat sandwich. Platysma supplies the skin of head and neck with facial artery and facial nerve, which is its supply. What is the nerve supply of platysma? Facial nerve. What's the blood supply of platysma? Facial artery. Where is the platysma existing? Platysma is existing like this. So it will be missing in the posterior part and it will be missing in the midline. And how do you find out the direction of fibers of platysma? It just opposite to the direction of fibers of sternocleidomastoid fibers. I think Busha, you got it. And so why not? This is Aishwarya. So why not squamous cell carcinoma caused by tobacco chewing is treated in initial stages rather than making it Oh, we will treat it if the patient comes. You should work towards it. They should come early. And first of all, nobody should take tobacco. Tobacco is a killer. Smokers, tobacco chewers. Tobacco is taken in two forms, smokeless and smoked form. Smokeless form is worse because they take the canning, which is called a quid, and they keep it in the lateral sulcus, which is called therefore the lateral sulcus cancer. Lateral sulcus cancer is the classical Indian oral cancer. Do you know the most common cancer in Indian men is oral cancer? And I treat oral cancer. Please go on the web of my YouTube videos on oral cancer. You people are too lazy and you don't visit those areas. Visit the YouTube channel. You get lots of answers on tobacco causing oral cancer. What have we done to introduce oral self-examination, what we call as OSC. I teach patients to examine their oral cavity in a mirror. Some of they say we don't have a mirror also. Now you can look into the mobile phone and see. In good light, you can see an early ulcer. Don't allow it to grow. I agree with you. Pandya got an answer. Sensory examination. This is Pragya. Remember of the limb it was. Very often I've seen people mention sensation lost 1 centimeter above the foot, 2 centimeter above the ankle joint. That's a wrong way to describe it. Describe it in terms of dermatomes. And remember, it's a sensory system that's lost first. So if you know sensory system is normal, the motor system is likely to be normal. Is that okay? Now, sensory system, you should examine in the dermatomes. And what does that mean? In the upper limb, the dermatomes will be different. The lower limb, they will be different. But describe in terms of dermatomes. So that will indicate the site. So if you put your hands in the side pockets of your trouser, this is L2, this is L3, that is L4, and below that is L5 laterally. Then on sole, your S1, medial side of the limb, it will be S2, S3 you sit on. That's easy to remember. That's why I explained it that way. Thank you for that. Yes. Amneet Kaur has asked a very good question. Why phylloids don't involve the skin? For that, you need to go back into phylloids. Phylloids are not tumors. They're not cancers of the breast unit. What is the primary unit in breast? It's called TDLU, terminal duct lobular unit. There's a ductal system, there's a lobule. That's what is breast. And then there is a stroma around it, right? Phylloids develop in the stroma. So they don't involve the skin. Breast is a modified sweat gland. It's actually skin only. So in cases of the infiltrating duct carcinomas or the carcinomas of the breast, it is the duct unit which is involved, through which the cancer goes to the skin and can directly infiltrate the skin. In phylloids, it is just the size enlargement. And how does ulcer happen in phylloids? By stretching of skin and ischemia. So it's an ischemic ulcer. And how do you know skin is not involved in phylloids? Since you asked me a question, you find an ulcer. How would you know it's not direct involvement? We do what is called as a probe test. You do what? You put a probe under the margin or the edges of the ulcer, and you can roll it around. If the probe test is positive, it indicates skin is free. I think there are no more questions. Okay. Sanjeev Kumar Reddy, you're back again. You did well yesterday. Sir, how will you differentiate fibroadenoma of the breast from phylloids tumor? Well, it'll go on, and I'll not stop until the organizers say they're terribly running short of time or they're hungry. Because when I teach, I forget everything. So I don't know where the time is, where am I? And therefore, my connection, if it goes away, I get very disturbed because I am used to teaching in the classrooms with a chalk and talk. I don't believe in any PPTs. I like to draw and just keep making. And the board would be filled at the end of it. I'll keep writing, and then but I don't know where to rub. They will ask me to stop it. So nowadays they'll take a picture and then I'll go again. So remember that. So that iPad really looked very handy to me always because I could keep scribbling, keep drawing people and the ulcers and what you have. Coming to your question, I'm sorry I distracted. Fibroadenoma, right? Fibroadenoma is basically a benign lesion. Please visit my very relevant video on triple assessment in breast. There are 2 YouTube videos which are very important for every undergraduate to watch. Please watch them. They cost you nothing. You will enjoy. That has got a description. What is ANDI? Aberrations of normal development and involution. So fibroadenoma is not a disease. First, remember that. It's an aberration. So if some patient gets a fibroadenoma, don't advise get it resected. It doesn't need that. They're common development errors. So aberrations of normal development would mean what? Around puberty, the breast is developing, aberrations would happen. So they can be small little nodules, right? And when the breast is involuting, that is menopause, these are supposed to close. They don't close. The ducts remain patent or ductectasia, or they remain patent and they get filled with fluid, fibrocystic disease. And you can have sclerosing adenosis, precancerous. And in between is an active part of breast, when breast is supposed to be active. Basic function of breast is breastfeeding. And it is when you get fibroadenosis, which is hormonal dependent. So fibroadenoma is an aberration of normal development and involution. Understand that first. When fibroadenomas grow large, we call them giant fibroadenomas when they're more than 5 centimeters in diameter. That's when comes the suspicion. So one thing, phylloids would be larger than normal size. They'll be harder than normal fibroadenomas. They may not be fixed to begin with, so they can be confused. Many a times you make a diagnosis of fibroadenomas or phylloids. So any giant fibroadenoma should be treated as a phylloid, unless proven otherwise. I hope you understand. What does that mean? I'll subject every breast disorder is subjected to triple assessment. You know that. A good history and examination, as I've taught you today. I'll talk about breast examination some other time whenever we interact. And imaging, which is in the form of ultrasound in younger patients and mammography in older patients, like more than 35, less than 35. Or denser breast, ultrasound, less dense breast, mammography. Why? Because the breast parenchyma looks white and the lesion on mammography also looks white. So you can't make out white against white. So in a denser breast, ultrasound is superior to mammography. Secondly, you don't want to expose a 15-year-old girl to X-rays. That's a second reason, not the first reason. So don't answer the wrong way. And then once you've done an ultrasound, you can do a core needle biopsy, not FNAC. FNAC is outdated now. Nobody does FNAC. Core needle biopsy gives you tissue. FNAC gives you cells. What would you want? Tissue, no? And tissue can tell you whether it's cancer or not, for sure. Less false negatives. It can tell you whether it's invasive or not. Less false negatives. Invasion can be seen only through the capsules. You need tissue. FNAC cannot tell you that. It can also tell you the grade of the tumor, type of tumor, and also biomarkers, the ER/PR status and HER2 status. That's where core biopsy is superior. So that's how you differentiate. One, larger size. Two, I'll do triple assessment. On core biopsy, what would I get? Phylloid has different features suggestive of connective tissue problems, while uh, fibroadenoma is an epithelial problem. Clear? If you understood, please answer. Otherwise, I'll feel that you didn't get it. This is Digala Sarkar. Got it. Okay. Tanmay Chawarkar. What's the management of grade 4 bed sores? Well, come on now. That's beyond the scope. Grade 4 bed sore patient management is important. I taught you. Don't treat the whole alone. Treat the patient as a whole. So manage the patient, manage the site, and then manage the ulcer. Patient is managed by taking care of nutrition. It's commonly seen in patients who are lying still or they are bedridden because of some reasons. You need to take care of that. Their positioning should be regular. The part should be kept dry. The bed should be more comfortable. You should use pneumatic beds. You should tilt the patient either side. You grade bed sores based on WHO criteria. This grade 4 is no longer applicable. And then what do? We try to clean up the wound, debride it regularly, regular dressings, postural management, nutritional management, patient as a whole, diabetic treatment, whatever is the problem should be treated. Then coming to the wound last, you can treat it by various methods, including vacuum-assisted closure techniques, which are vac dressings or very specialized dressings. Please visit my YouTube channel for management using vac therapy. I think there's one more question which is completely out of context, but I won't disappoint you. What is the investigation for duodenal atresia? You can answer that yourself. How do you reach duodenum to know that duodenum is diseased? You can reach by throwing a dye, taking an X-ray, that's one. Or you can put a instrument with a torch in it, that is using an endoscope, and do it. And third is you can send some doctor inside with a torch, he'll find out. That can't be done. So you can have a robot for that, and you can have a video endoscopy. So I've given you all three answers. You can do a barium meal, upper GI, or you can do an upper GI endoscopy, or you can do the video assisted endoscopy. But this is too late in the day. You should take a good history, man. Don't forget that. And what would be the history of a patient with duodenal atresia? He'll have features of gastric outlet obstruction, which would be he has taken something and after some time he throws it out. Now, if it is below the point where the common bile duct opens, it will be with bile. If it's above that, it will be without bile. Therefore, when you have pyloric stenosis, it is a non-bilious vomiting. In duodenal atresia, you may get bilious vomiting. I think in that short time, I could cover that part only. There's no end to it. And please do write if you understood. I think that should be it. Now, before I conclude and I hand you over to the wonderful organizers who were very patient with the goof ups that happened at my end, for which I am very, very apologetic. I don't like to keep people confused about things. I would like to thank you all for listening and indicate in the chat box you enjoyed it as much as I enjoyed getting it to you, because I found you very intelligent students yesterday and also today. Please do mention in the chat box, and you can still ask a question. I am never tired. So you can ask a question in next 2 minutes quickly, or indicate that you're done and I'll move on. While you're writing it, please visit the YouTube channel. You'll get questions. I'll suggest it to all the organizers, Kushman and all her team and others, to make use of it. It's meant for all of you. It has nothing to do with, I have just been, my students are all over the world and they're asking me to expand the classroom. That's how it started. And my students only start expanding it. I don't get time for many things, but I always give time for this because it's very important. So I would recommend that you go there. And then they insisted on me bringing out a book on it. So now there are books, about 10, 15 books there already that I've done. I can never write, I don't have time to write books now, and it's not needed. So I speak the book now. So what is important is you'll get an ebook which is completely videos and talks. And I like to hear a talk like that. When I was a student, I would have loved it if somebody just spoke to me about it rather than give me to. I mean, there's a very old, very good number by Beatles. If you listen to good songs, a teacher, leave these kids alone. That's one way to learn. And if you want to learn, burn your books. That's the way to learn. So improve your understanding. Information, there's no end to it. It'll keep on changing, but understanding cannot change. People can provide you information, but they cannot provide you understanding. So what you should develop is wisdom, which is understanding plus knowledge. With that, I'll conclude it. I'll hand you over to the organizers, and I thank you all for listening patiently. I'm there for as long as the organizers want me. Otherwise, I'll peel off quickly. Over to you, and thank you very much.
Thank you very much, sir. It has been a pleasure having you. It has been more than a delight for everyone who got to hear from you. And I must say, the review has been amazing. And everyone has enjoyed the session pretty much as we have enjoyed hosting it with you and getting this opportunity. So thank you for the wonderful 2 days you have given us. So much to learn, so much to know more. And I must say that you have started that unfinished quench to learn more and we're so thankful for the YouTube videos that you share with everyone on your channel. I must say they're really going to be helpful and have been helpful for hundreds of students ever since. So really thankful. As regards to the delegates, thank you so much everyone for joining us at the session today. Kindly fill in the post-event feedback form. I have sent it in the chat box. I'll send it again. We'll be here till 1. If you have any queries regarding anything, we'll be happy to help you out. We won't take much of Sir's time, and we'd like to thank him once again.
Thank you very much. Thank you very much for having me. It has been a pleasure to associate with AMSA, and I must compliment you for doing a great service. Make them learn, and that's how it should happen. Can I leave now? Thank you very much.
Yes, sir. Thank you so much.
It's been a pleasure.
Thank you, sir. Thank you so much, everyone. I'm sorry, sir has already left, so we could not answer your last question. If you want, you can email them at gurukulsurgery@gmail.com for your queries. And besides that, thank you so much to all the participants who joined us at the session today. It was wonderful having you all. Thank you to all my co-hosts for being so compliant. Malika, Anshul, and Rebecca, it has been a pleasure. And this wouldn't have been successful without you guys. So thank you so much. As regards everyone, kindly fill in the form, because if you have filled both the pre-event and post-event forms, only then you will be able to avail the certificate. And we'll be here till 1, so that if you have any other queries, feel free to ask them. Thank you.
So guys, you can just email your doubts to us on amsageneral@gmail.com. And with this, we will end our meeting. Thank you so much for joining us.
thank you so much, everyone, for joining us. We'll be ending the meeting now. Hope you had a great time. See you soon in more AMSA endeavors. Viva AMSA.